Hello, my name is Richard Bay, and I'm the director of the Echo Lab at the Minneapolis Heart Institute. My assigned talk title is Fancy Probe Manipulation. Here's my disclosure slide. Since there is only so much you can do with the probe in the tube that is the esophagus, the theme of this talk will be transgastric imaging. The first example comes from the world of tricuspid valve clipping. Here, the goal is to create an edge-to-edge repair of the tricuspid valve using clips, similar to MitraClip with a mitral valve. However, tricuspid valve clipping is much more difficult than mitral clipping from an imaging standpoint. The tricuspid valve leaflets are thin, there can be shadowing from the atrial septum, mitral annuloplasty rings, or mitral or aortic valve prostheses. The leaflets are not perpendicular to the insination beam, and the valve is located in the far field from the esophageal position. One of the critical views we have described for the procedure is the transgastric short axis view. This gives us the best definition of the leaflet anatomy and visualization of the coaptation gaps. Here we see that the transgastric short axis view in the lower right best shows us that the valve is actually quadricuspid. This view also shows us the leaflet tips and potential pacer lead interaction with the leaflets. Here the pacer lead is seen interacting with the septal leaflet. This view is also helpful in clip arm alignment and positioning of the clip along the commissures. We also use this view to confirm a good tissue bridge once the clip is closed. Ideally, we like to visualize the leaflet grasp from the esophageal windows, typically in a long axis view or grasping view. Here we see an NTR clip being used. The leaflets are seen resting deep into the clip arms, and a grasp is performed with relatively high confidence. Similarly, an XTR grasp ideally is imaged in this view. However, not uncommonly, shadowing issues or other technical limitations prevent good visualization of the grasp or leaflet insertion from the esophageal windows. In these cases, I have found that sometimes this view can be helpful. It is a view from the mid-transgastric position, somewhere between the shallow transgastric short axis view and a deep transgastric view. Adjustments also need to be made in right-left flexion to optimize this view, where you can see the leaflets inserting into an upside-down view of the clip. Here's another example of this upside-down transgastric view. As the clip closes, an off-axis view can sometimes look like this hybrid view, with the leaflets inserting into the clip arms, and the image above the clip looking more like a short-axis view. The clip can then be closed under color to watch the tissue bridge and location of any residual tricuspid regurgitation. If the transgastric short axis views are good, 3D multiplanar reconstruction can also be performed and manipulated to show leaflet insertion. Here's another example of 3D multiplanar reconstruction from transgastric views that demonstrate leaflet insertion. While the transgastric views are often helpful, occasionally you may need to resort to alternative imaging such as transthoracic imaging. All that practice scanning patients with the TTE probe as a fellow can pay off in the cath lab. Imaging the tricuspid valve can be technically difficult. There are important imaging views needed that are not routinely obtained. The transgastric short axis view is critical. When grasping or leaflet insertion is not well visualized from esophageal views, off-axis transgastric views or even multiplanar reconstruction from the transgastric imaging can be helpful. Occasionally, adjunctive imaging can also be helpful to assess leaflet insertion, such as transthoracic imaging or intracardiac echocardiography. This is another case where transgastric imaging was helpful. A 56-year-old woman with a history of staph endocarditis who had previous aortic valve replacement with a homograph, tricuspid debridement, and VSD repair. She had residual LV to RA Shunt with a QP to QS ratio of greater than 2, ascites and dyspnea, and she was referred to consider percutaneous options. Here we can see clearly that there is an LVOT to RA shunt, both by color flow and Doppler imaging. However, during the procedure, crossing the defect from the right atrial side proved to be difficult. This key transgastric view shows us why. Here we can see that the defect has a windsock appearance and that crossing from the LVOT side might be easier. So that's what we did. Here you can see a wire being advanced into the RA from the LVOT side. This was then snared in the right atrium to create a rail. A catheter was then advanced over the wire from the right atrial side, and a vascular plug was deployed to seal the defect. Back to the transgastric views, here we can see that there is no significant residual shunt and that the discs do not impinge on the tricuspid or aortic valve leaflets. The key points are that if a standard view is not working, try non-standard alternative views. In this case, transgastric views were instrumental. Don't forget the stomach. Thank you for your attention.